Hello, everyone. This is Paul Saraja from Minneapolis, and it's really my distinct pleasure to welcome you all to this webinar on ultimate aortic cases hosted by Cardiovascular Innovations. And we'd like to thank Boston Scientific, Medtronic, and Philips for sponsoring this symposium. I hope you enjoy this this evening's session. We're going to go over a number of cases by a wonderful group of experts. And we're going to start with Guy Arizani first here. Guy?
Thank you, Paul, for the invitation. It's a pleasure to be part of this. I'm going to share with you a case of bicuspid aortic valve TAVR that we did here in Cleveland. I am the director of the structural heart program here at the University Hospitals. We did this case some months ago, and we know that there are a lot of controversies in bicuspid aortic valve, so it's going to be great to discuss with the distinguished panel of experts here. So this is a 79-year-old female with a recent diagnosis of invasive ductal carcinoma. And they basically discovered that she had severe aortic stenosis while during the workup for the surgery for that. With an aortic valve area of 0.34, dimensional index of 0.11, and a mean gradient of 90, with a normal low ejection fraction, a peak velocity of 5.8 EKG. So here's the echo. As you can see here, my echo is not playing, but anyway, she, as you can see here on the short axis, bicuspid aortic valve with the mean gradients that we discussed. Heart catheterization was normal. With her axis was good as well for a transfemoral TAVR. This is one of the important points of the discussion. I'd like to hear everyone's opinion on it. João's opinion also on the CT scan. But basically, when we look at the perimeter of this patient, 84.5 with an area of 532, STJ with 28, 29. Sinus is all above 30 millimeters. And when we measure, we can see the bicuspid valve here, a fusion between the right and the non-coronary cusp with a calcified raphe. And we measure this, when we perform a supraannular measurement of this patient, we can see that the perimeter is a 75 perimeter with an area of 338. Now, the number one question here is how to size appropriately in bicuspid valves. I'd like to just stop a little bit, if you allow me, Paul, and ask Sushil, Steve, João, and you, of course, how do you guys do the sizing of bicuspid valves?
Great question. Steve.
Yeah. So I know João's got the final answer, which is appropriate, but
I don't think nobody has the final answer.
Yeah, we look at everything. So when I do the sizing of this, we do an annular measurement, we do an STJ measurement, we do 5 millimeters above the annular plane, and we look at the LVOT, and we come to some sort of decision. If you have to pick one measurement that I would say, if I had to do one measurement, it would be the annular measurement like we do all other valves. I think at the end of the day, having sized them in many, many different ways, you take everything into account, but the final measurement's the annular measurement.
I agree completely, Steve. I think there's a nice recent work by actually the group from Jonathan Leipzig showing that the reproducibility of the annular measurement, even though you might exclude some of these patients, just like what Guilherme has shown, the annular measurement is much larger with a perimeter of 85, 84, 85. You tend to be much more reproducible. But we look into the constellation of things, as well as the degree of calcification, the LVOT as well.
I think the only thing I would add is that I think there may be some differences based on what valve you're going to use, and also all bicuspids are not the same. Mm-hmm. If you have a type 0 with a really long leaflet and you're doing a balloon expandable, one of the concerns is that you have to be at the top of the leaflets, right? You got to at least anchor at the top, otherwise you're going to end up down. And maybe we'll talk a little bit in a second about valve choice, but I think the type of bicuspid and valve choice probably does play some role as well. And this heavily calcified, if you go back just maybe 2 slides, I don't want to,
No problem. I can go back to show here.
Yeah. You see that really calcified raphe. If you're doing a balloon expandable, many of these cases, that raphe is not going to allow the valve to sit in that direction, and everything's going to be canted in the opposite direction. In this case, towards the left main, it looks like. And so that distance to me, when I'm doing a balloon expandable, I look at, because sometimes all this, we always learn by our own stupidity and our own mistakes. And one time I had a sinus that was enormous, and it was a right non-fusion, and I put a sapien, and I included the left main because it didn't expand in that direction at all. Even though the sinus was enormous, the whole valve deployed towards the left side, and I included the left main. So there are things that it's hard to really, how the different valve types and, sizing, but I agree also. I focus on the annulus.
I think, that you make if I may just make a quick point too, that looking at the post-implant CTs also will teach us a lot, right? How much of that raphe that is so calcified will give in will probably preempt you to kind of do something such as, a laceration or something like that, that also could facilitate that deployment.
Yeah.
So how does, can I just ask, so obviously there are multiple valve choices here. So there's annular, there's 5 millimeters above. What other ways of sizing it, perimeter, diameter, what have you? Can each of you just tell me, for Edwards, for Evolut, for Lotus, or others, what is your preferred way depending on what your valve choice is going to be? Steve, you want to start?
Yeah, I think I make the decision based upon the calcification, especially annular calcification, and then what that raphe looks like. So that raphe, I agree with Sushil, that thing's not going to split. It's going to impact the shape of the valve. And so I would not use a balloon expandable valve in this particular instance. And I would either use a self-expanding, which is the one I have the most experience with. And the other consideration, depending on how much LVOT calcification there is, a Lotus would be my second choice. But this sizing might be a little bit too big for Lotus. But I definitely would consider a self-expanding as my very first choice.
And do you go at the annulus or above the annulus, Steve, for your sizing?
Annulus. At the end of the day, we take everything into account, but the annular sizing is what I usually go by.
Sushil?
So I think for balloon expandable, I'd use annular sizing. I think if there was a large sinus and that distance from that raphe to the left was adequate with the size valve I was going to use, I would feel comfortable with balloon expandable. But if it's in a phase sinus, there isn't room. I think self-expanding is sort of clearly the preferred choice. For self-expanding, I do look at the annulus, but I also look at the intercommissural distance. I mean, if we're sizing to a 34 and that intercommissural distance is like 27, I'm just worried with these tall leaflets with that shoulder, it's just going to dive deep. And I tend to look at that, and then if the intercommissural is shorter, I would do a 29 and sort of deploy high in those scenarios. Mm-hmm. And I really like Lotus. We've had some really nice experience with Lotus in this, and for that, I've generally done angular sizing.
I love Lotus for bicuspids. I really do. It's just the bicuspids that are too big is when there's a problem, right?
Yeah, particularly,
Yeah. All right, let's hear what you did.
All right. So great discussion here. Okay, so just the rest of the CT, this is the coronary height. So left 14.7, 12.4 for the right. And here is I do just a call. I do supraannular sizing when we're dealing with bicuspid valves. I think João's point is very important. The fact that there is less reproducibility when you do supraannular sizing on your measurements. However, the sealing mechanism really is going to happen in the commissure in this scenario. So therefore, I do my sizing based on the commissure measurement, and therefore I aim very high implantation for these valves. I agree with Sushil that depends on the anatomy. It's not all bicuspids are not the same, but when you have a situation like this very calcified raphe or a type 0, I always size supraannular and I implant very high. CT scan then really, when thinking of a self-expandable valve, if we were going to size based on the annulus in this patient, we would have picked a 34 valve for Evolut. However, the perimeter of the supraannular perimeter is 75, and the other measurements all compatible with a 29. So I chose a 29 Evolut Pro with a pre-dilatation of a 20 millimeter true dilatation balloon.
Real quick, can I ask that pre-dil? I pre-dilate all bicuspids, and I've been, especially heavy calcium, low threshold to pre-dilate. What size? How did you choose that size of 20?
I usually choose to show based on the minimum diameter that is going to interact with the balloon. Based on, it can be the raphe, from the raphe to the opposite side. So that's based on the minimum diameter, whatever interaction the balloon is gonna have along the way. I based on that basically.
How about if you use Lotus? Do you still pre-dilate?
I don't have a lot of experience with Lotus, Steve, so I don't know. I don't know. I
Yeah,
predilate
yes.
100% of my bicuspids, but for Lotus, I don't have a lot of experience. I apologize
yeah,
that my
almost always. Yeah. In fact, I think it's almost mandatory for Lotus because otherwise you do run the risk of asymmetrical expansion. And so I would recommend pre-dilating if it were Lotus.
I apologize that for some reason my films are not playing. They were playing perfectly yesterday, and I really apologize for that. They're not playing. I apologize for that. But basically, this is a regular pre-dilatation. I want to just to make sure that although I don't have the injection here, you can see where my pigtail is sitting in the bottom of the non-coronary cusp here, as you can see. And although you don't see the picture, but if you look at where my valve is sitting there, right? You can see that my valve is very, very high, right? So 29 valve implanted very high. You can make the number you want there, but minus something, right? Very high implantation.
So you are the pro at this. I've seen you do this multiple, and it's always uncomfortable. So for some of us, and I really admire this high implantation technique. Now, just before we keep going here, quick question: cusp overlap view. How do you do that with a bicuspid? Do you just focus on the non? Tell us how you do that.
That's a very important question, Paul. I don't do cusp overlap. I basically implant my valves in LAO. This is a technique that I've been doing since forever, and I don't do cusp overlaps. I just do LAO. I just go LAO, take the parallax out, and implant basically.
You can see the incomplete expansion around the nun and right there, right? I mean, you can see that it's not going to give in so much.
Yeah.
I think what's always scary is when you go RAO in some of these bicuspids with the core valve, and it's important to do because if it's really pancaked. So the question I have is, say you go RAO and it's that pancake, do you take it out and do a more aggressive balloon?
Not really, Sushil. I don't actually. When I go LAO, I'm happy with because the question is, if we're going to react all the time to this, I'm not sure what is the appropriate reaction. Should we remove the valve and pre-dilate more aggressively? I don't know. I don't think we have a clear answer for that. However, the pre-dilatation was done based on those measurements that we just discussed a minute ago. So I wouldn't feel extremely comfortable going with a true dilatation balloon and dilating more aggressively, unless when I am at LAO, I see the valve extremely constrained, that expansion is impaired, then I would do that. Other than that, I don't routinely go RAO to see if the valve is expanded or not. Do you do that normally or not?
And I don't know. Bicuspids I do. My main concern is that the nose cone catches on the way out if it's really pancaked. But I don't know. Steve has a lot more experience with core valve than I do, so I don't know. What do you do, Steve?
So I'm fascinated by Guy's implantation depth because on these bicuspids, especially the valve looks a little constrained, and I tend to post dilate them, not that uncommonly, just to make sure that the valve frame looks like potentially what the valve should look like in an encumbered environment. I do want the valve to be able to function adequately. And when you do post-dilate, there's a chance of the valve moving, especially north. So what do you do in those instances, Guy? If you feel like you need to post-dilate and you're already at +2, how do you prevent that thing from migrating into the greater vessels?
So it's interesting because my fellows, and then when we have our courses here, people ask me this question, right, Stephen? So do you fear to post-dilate a valve that is implanted high? I don't fear. I respect the fact that the valve is implanted high, right? So if I have to post-dilate, I will definitely post-dilate. Of course, respecting the fact that the valve is high and making sure that I'm going to have a good pacing capture, that I'm going to only call for pacemaker off when my balloon is completely deflated, right? Is there a risk of moving north? Well, there is a little bit of a higher risk. I think we have been successful doing that here. We are, in addition, Steve, one thing, we predilate, not only bicuspid, but in general, we predilate more often than the number in the US, as you know, of predilatation is around 30%. We predilate around 60% of our valves, but we rarely post-dilate. Post-dilatation, we post-dilate less than 5% of our valves, and the number in the US is around 30-35%. Because I implant high, I tend to predilate more to avoid post-dilatation. Of course, in bicuspid, this mathematics doesn't work all the time, but we've been successful, but we're cognizant of the risk of higher risk of migration north. Well, so I would like to show you the echo. I apologize again for this not playing. This is the first time this happens with this presentation, but anyway, I promise you that there's no paravalvular leak, okay? You guys are gonna have to trust me here on this one. No PVM.
Well, that image was frozen in diastole, so we trust you.
The only one thing that I would like to discuss here, I'd like to hear everybody's opinion on, as you can see here on the TTE, right? The valve is like in an oval shaped fashion here. And to Sushil's point here, what to do now? The gradients are great. I'm gonna show you here. So mean gradient of 7, no paravalvular leak, but we have an oval shaped valve. Sushil, Steve, João, and Paul, should we post-dilate this valve or should we just leave it as it is?
Your hemos are great. I'd walk away.
Same here.
Agreed.
There's not.
It's post-dilating that is cosmetic.
Yeah.
You know, the only concern I have about that is, well, first of all, I wouldn't post-dilate it because I would be afraid of this thing moving out of position. But I just wonder, the valve is designed to be open in, you know, in somewhat of a circular configuration. I know it's the annular dimension is not reflective of coaptation of the leaflets perfectly, but it is somewhat affected. And you just wonder, will the stent frame deformity at the annular level affect the long-term outcome of the valve? Guy, do you have any information about that?
No, not really, Steve. I think it's a very important question, right? In terms of, again, the fact that the valve is supraannular, right? We would expect that there is a circularity in the coaptation level of the leaflets, and it's not as much affected by that elliptical shape down in the commissure. But there's no data. I mean, I agree with all of you. We didn't post-dilate this valve, and there's really no data showing that this cosmetic post-dilatation that would theoretically improve the circularity of the frame would lead to, you know, better long-term outcomes. I think we're still in the infancy of a complete understanding of bicuspid intervention.
Some anecdotal case that we have seen with some bicuspids too, you know, due to this incomplete expansion of the valve, sometimes there's actually some thrombus in the sinuses because of the incomplete washout. Not inside, not a halt, but outside, actually, that we have noticed that. And I was going to ask you a quick question here. You implant high, and that's a beautiful results here, Guy. Any concern about coronary access?
Yeah, with this, yeah, that's a good question, João. This patient, as you could see in this CT, her anatomy, I mean, she has a very, very large STJ and large sinus of Valsalva, so not really. I think we can, this patient is a patient that we can get coronary access. If her anatomy was smaller, right, and in fact, I think this is a very appropriate question, João. I think for there are some patients, some situations that I elect not to implant the valve. I did a case this week, very interestingly. This week I did a case of a patient that had narrow sinus, narrow STJ, and a low takeoff of the coronary. We decided to implant the valve deeper. We were doing good oversizing just to enable future access. Some concern with acute occlusion, but deeper implantation on purpose to enable future access to the coronaries easier. And this is something that we do. We can customize this per patient's anatomical features. But in this patient, I really don't have significant concerns. She has very wide anatomy, wide sinus, wide STJ, and takeoff of the coronary. So I wouldn't be significantly concerned.
All right, this is perfect. We probably should get going. Do you have more slides to show there?
I do not, Paul. Just a conclusion slide, but
Okay.
that's basically.
I have one last question for you.
Mm-hmm.
So because you are really an expert at high implantation, I've seen you do this expertly so many times, and obviously the concern about post-still and migration with post-still takes some of the fear, creates some of the fear among us, including me. Have you ever had pop out with post-still of a high implant?
Not with post-deal, but I've had pop out with nose cone. When we were retrieving the nose cone got caught on top, and we were, the team were paying attention, but the nose cone came to the inner curvature of the aorta, and we had a pop up. And there was another case that I usually pull the wire inside the nose cone to remove everything. I don't keep wire in the ventricle, but there was a case that there was a little bit of wire that was, distal to the nose cone, and the wire got caught on top. And when we pulled the wire, pulled the valve up. So we had two cases. It's rare, Paul. I mean, considering the number of cases that we do, and both cases we were able to snare and put another valve. They had great outcomes. Again, there's always a price to pay for everything you do. I mean, I think our commitment with in high implants and reducing pacemaker rates, I think we have been very successful overall. But yes, we have had a couple of cases that we had embolization.
But it doesn't appear to be due to the high implant exactly per se, or post-still.
No, with post-deal, we've never. But as I said, Paul, keep in mind that we post-dilate rarely because we pre-dilate much more often, right? That's one of the reasons why I pre-dilate more often, is because I reduce the likelihood I'm gonna have to post-deal because I implant high, right? So I want to avoid that if I can.
What tips do you have, Paul, to prevent pop-outs on post-dilatation?
Well, I basically I don't post dilate when it's high.
Okay.
And I think one thing I would say though is you want to make sure the shoulder of the balloon isn't right at the bottom, like that you are really centered at the annulus. And then it's the angles, right? So if your balloon is coming at an angle and your aorta is at this angle, as you inflate, it's going to do this. So if the balloon trying to understand the angles, and as it does that, it may pull it up. So trying to keep the balloon as you go up coaxial to the frame of your core valve, I think is important as well.
Yeah, I like to use the TAV8 balloons because I like the bulb to inflate the inflow to make that as round as possible. But if it's a high implant, I would not recommend a wasted balloon because that can theoretically pop that part out further than the rest of the valve. But as always, Dr. Artesana, you've inspired me again. So thank you very much for that.
Thank you, and I apologize once again for my slides that my films that didn't play.
No, the discussion was fantastic, and we could see everything you did from your slides, even without the movies, for sure. So, all right, we'll move on. We have Dr. Joao Cavalcante. Joao, you want to take it from here?
Yes, Paul, thank you. Let me see if I can this up here. You can see my slides, correct?
Yes.
All right, good. So thank you, Paul, and great to see friends here virtually to present this case that we had a couple of years ago, actually, at Minneapolis Heart Institute. So there's an 80-year-old male that presents with progressive exertional dyspnea up to now class 3 symptoms. His past medical history was significant for significant hypertension on at least 3 antihypertensives. He had coronary atherosclerosis and had a small troponin elevation labeled as non-STEMI, which at that time the coronary angiogram had revealed no significant obstructive coronary disease, as well as a prior surgical AVR. It was a 25 millimeter trifecta, or 12, at that time now 10 years ago, had presented also with hypertension and chronic kidney insufficiency. He had a murmur, the crescendo murmur of the right sternal border, diminished as 2, And outside reports for both a transthoracic and a transesophageal, which I don't have access to those images, have revealed a hyperdynamic LV with a mean gradient of 30 with severe eccentric AI. And there was no evidence of paravalvular regurgitation. He came to us for evaluation for potential valve-in-valve. As you can see on the top images there, those are reconstructed CT images, multiphasic acquisition. There's leaflet calcification and incomplete leaflet closure involving both the non and the right lobes. The CT also confirmed, the CT also confirmed that true internal diameter of 23 millimeters. And then this is on the right here, you can see the calculation of the virtual transcatheter to coronary distance, which was favorable, about 6 millimeters for both the left and the right. We have patent coronary arteries. So to empathize with Guy, I don't have also the video for the implantation here, the still frame. But as you can see, this is a prior to the deployment of a 26 Evolute Pro into the 23 valve that he had. There's a trifecta, it's a non-fracturable valve. And procedure went well. There was no significant mishaps there. And he was discharged with a peak aortic valve velocity of 2.8 meters per second, peak and mean of 31 and 16, dimensionless index of 0.39, and a calculated EOAI of 0.8, so no PPM and gradients. Just open a question now to Paul, Guy, and to Sushil, and Paul as well. Would you have done anything differently here?
Well, I think the question here is, even if you can't fracture, do you believe in BVR? You know, and I think that's what a lot of people are starting to think about, whether you can modify the outflow with a balloon or not. Steve, Guy, or Sushil, what do you think? Would you consider BVR here?
Yeah, you know, it's rare that we'll put do valve-in-valve TAVR without post-dilating at the end. You know, so often I see that the TAVR valve is not fully opposed to the surgical valve, even though you don't have PVL. It looks like there's space between the surgical valve, and that might be the inner diameter that I'm mistaken for. But I love to put this valve out as big as possible, and even if it's non-fracturable, I'll still post-dilate this, and I depend on my catheter gradients in the cath lab when I'm doing the procedure, more so than the echo gradients. And I wanted to know if Joel thinks that that's a reasonable thing to do when you're doing the procedure. So I'm trying to walk away with the lowest possible gradient in the lab. So I'm going to post-dilate even if I have a decent result like this.
One comment here. The valve, the trifecta that is in place, I assume you perform the calculation of whether or not there was patient prosthesis mismatch. So when I go on a valve-in-valve case, I always go with a certain expectation, right? In a sense that if this patient with a 25 trifecta, if there's no patient prosthesis mismatch, my expectation is that if I do a great implant depth, it's hard to see here the depth of your implant here. It's really difficult to see, but if you deploy the valve in a good implant depth, right, the expectation is that I'm gonna have single digit gradients, right? Even more so when you're dealing with a supraannular valve like you're using here, right? So I do perform, as Steve mentioned, I agree with Steve, I do post-dilate my valve-in-valves very often, because yes, very often you see that lack of expansion because there might be panels there that when you do post-dilatation, in this case, I would pick just a 23 millimeter balloon. It works very well and reduces gradients, but yeah, we do it quite often.
So if you don't do BVF, you're doing BVR, what's your balloon of choice?
I'll just say that what I typically do is I go 1 millimeter more than the inner diameter of the valve, at least. And I typically use a true balloon.
Guy, also for you, true balloon?
Yes, true balloon.
Now, Joel's probably picked it. This is probably one of my cases, and I probably didn't post it, and now he's going to accuse me of mishap here. So we'll keep going.
No, we'll keep going. It's going to get interesting. So great discussion. So there was no post dilation. Go ahead.
Gradients at the end of the procedure, right?
Yeah.
Either by echo or by cath, did you?
Yeah, so I am looking at the report that was generated here, and post-procedural invasive hemodynamics demonstrated a peak-to-peak of less than 5 millimeters.
Okay.
So,
Okay.
so there is significant discrepancy there. So it's hard to argue that, one should consider doing, anything. And patient was discharged on depth, platelet. And then at 30 days, as routine comes back, and you can see that the gradients by echo again are fairly unchanged, 26, 16. The left ventricular VTI, outflow tract VTI, slightly up a normal 26 or so, preserved ejection fraction and calculated EOAI, again, no PPM with a good dimensionless index. We do, as part of our registry here, also CT at 30 days. We're collecting this data prospectively here, and you can see that the valve is properly expanded, perhaps seated a little bit more deeper than we would like, but nonetheless, good apposition, no halt, no reduced leaflet motion. Then 1 year has passed. He's feeling well. There's no exertional dyspnea. He's able to do things without any problems, but a new murmur is heard at the 1 year follow-up. And as you can see, there's very trivial paravalvular regurgitation there. And you can see that there is now an increased gradient. The peak velocity now has increased to 3.3, mean gradient about 23. There is also increased flow, transvalvular flow, which VTI is higher than that. Because of these findings and because of the murmur that was heard on the exam, the CT now is obtained, and we can see that there is halt. And that halt actually involves only the left cusp. You can see here, so one cusp, approximately 50% to 75% of the leaflet extent. And there is reduced leaflet mobility. I'm just going to go back again one more time. I don't know why this gets stuck. But you can see that both in 2 projections, that there is halt. So now the question is, now what? What would you guys do based on that?
First of all, when you do valve and valve, there are some people that immediately put people on anticoagulation for a month or 3 months. Nobody knows what to do in those instances, just because we're putting in, there's a lot more metal. I'm going to assume that this patient was treated with single antiplatelet therapy, like most cases are done now anyway. And our criteria for treating patients for this visual appearance and this clinical appearance would typically be a gradient increase of 10 millimeter mean, which this didn't really fulfill.
Almost there. Yeah.
I think you'd have to be convinced that the patient's symptoms were due to this increased gradient before I'd put them on anticoagulation.
The only thing with gradient, though, I had one patient, I think significant cardiomyopathy, like an EF of like 25-30. Didn't really get a gradient increase, but when you looked at the calculated valve area, there was definitely a significant reduction. So I think the only thing I would say is sometimes I'm a little bit nervous about just using the gradient and really calculating DI and valve area and noticing a change. That's why systematic echoes at discharge in 30 days or post-procedure in 30 days are important, because you see that change.
Yeah. And I just wanted to point it out too, Sushil, that there was an increase also in transvalvular flow, at least measured by the LVOT VTI. And again, depending on where we sample, if this is right inside the valve frame, as one could consider, that could be closer to the valve, we're going to have a much higher envelope and we're going to have a much higher flow acceleration. But nonetheless, there was an increase in the gradient there between the pre-discharge, about 13, to even the 30-day 13 to now 23.
And Joe, where's the PVL coming from?
That's a good question. I mean, it might have been there actually all along. It is trivial, and it's hard to say whether this is coming actually between the stent frame of the evolute and the trifecta in between. you know,
I
because
suspect it's a little bit of a low implant,
yes,
looking at how it was sitting there.
exactly. So it could be related to probably the native valve and the low implantation of the evolute.
I would put this patient on warfarin, João. If this were a patient of ours here, I would definitely put him on warfarin.
Yeah, and that's what we would typically do too. You know, he's already had one valve and valve, and we're trying to help him avoid surgery.
Right.
And so you'd hate to see this get worse. Usually we don't see this with the change in gradients, and we see it with just the halt, and we struggle with what to do there.
Right.
But oftentimes we'll lean on just going and putting him on warfarin.
Yeah. And this is actually also a late case, right? And if we, after discussion with the patient, the family, the decision was to actually initiate, as you said, Guy, the anticoagulation with warfarin, drop the Plavix. And then this is just a paper that was recently published. Again, this is not involving valve. This is just native valve, but showing that this phenomenon of late halt can occur in up to 31% of patients, not much less so at the 30 days. So long-term surveillance and also reduced leaflet mobility.
How long do you have to keep them on anticoagulation?
So
$1 million
that's an unknown
question.
question, huh? Yeah, that's an unknown answer. I think what my take on it, you know, obviously participating in the valve team here too in the discussion, if the patients can tolerate with lower bleeding risk, I would probably keep indefinitely. Because you know whether this can be a harbinger for another recurrence of that, because we know that recurrence is quite high. You know, once you stop, it's almost 50% or so. They might come back, depending even how you look at it. And here we kind of look through the microscope of the CT, and so you know that might bite back. And so we can put him on anticoagulation. 6 months later, came back. You can see that the valve gradients actually have reduced substantially. It was 23, now it's 8. Yes, there might be some differences in blood pressure or how you measure, et cetera, but the halt is gone.
This may sound like a crazy question, but would anybody consider post-dilating this valve now? Knowing that maybe the expansion is not quite what you want to see, there's some hemodynamics, there's some halt. Would you look at or consider post-dilating this in any way, doing BVR?
I don't think so, because the trifecta can't expand, right? The trifecta is the one you can't
Can't
crack.
fracture, but could you remodel though?
Yeah, but how much do you think you would remodel there?
And that's a question. Can you do BVR of the outflow? And would that help with some of the leaflet expansion?
I wouldn't. I would just. I think you've been successful with your anticoagulation. I think João made a good point. If the patient has low bleeding risk, I would just keep the patient on warfarin, and your gradients are great, and halt is gone. I would avoid, I would say, a not necessary intervention right now. So I wouldn't do it.
So what I would say is
What does the mean gradient go down to at 18 months?
Yeah, down to 8 here, Steve.
So it's lower than when you left the lab.
Yes.
So so again, I'll come back to the question: should you anticoagulate valve-in-valve TAVR?
From the get-go.
Yes.
We have been given 3 months of anticoagulation for our valve-in-valve TAVRs, as long as the bleeding risk is not high. It's a reasonable bleeding risk. So we have been giving routinely. I understand that there's no strong evidence or no evidence at all behind that, but we have been doing that for valve-in-valve TAVRs.
With Coumadin?
With Coumadin.
Steve, Sushil, are you doing that as well?
I've been very aggressive. Unless they have any bleeding, history or acute bleeding issues, I've been anticoagulating. The thing I struggle with is warfarin versus NOAC. I mean,
Yeah.
And the role of NOACs in this population. The other thing I want to point out, this image is beautiful. You did perfect commissural alignment with your core valve. I am impressed. You got to teach me how you did it, because I try that, I never get it.
Yeah, I do give anticoagulation for 3 months. I don't know why 3 months. We may have picked it out of thin air, but that's what we do.
Yeah, so sure, you picked up on the image because I aligned precisely on the left main there.
Yeah.
That's exactly the point that I was going to.
I'm impressed.
Nice.
But you know, Sushil, you know, it's not irrelevant what you're saying. I mean, you know,
I
it's
worry about that.
visual alignment. You know, maybe the halt might not have gotten better. You know.
Yeah, no, you're right. I think that's one of the reasons, especially that you might get it because your diastolic washout's different. So
Yes.
we try to do it sometimes by reorienting and things like that. It's tough to predict.
Yes.
Yeah.
That's
So
great.
I guess just to conclude here, I think, you know, as we all highlighted here, there's no randomized trial yet for the anticoagulation strategy for these patients. Definitely need to borrow the multimodality approach to highlight, you know, how we can detect that. And a lot of the questions to me remain, and are these patients at a higher risk for halt development, therefore anticoagulation strategies? Is prosthesis patient mismatch and development for also risk factor for halt development? And could this be a precursor of prosthetic valve degeneration? So a lot of outstanding questions, and just would like to put a plug for our imaging fellowship. If you have fellows that are interested in learning more and learning with us here, Minneapolis Heart Institute, we're recruiting for 2021. So thank you so much again for this opportunity, Paul.
And you can see that most of the time we socially distance on the left-hand side there.
All right.
Fantastic. That was great.
Great case,
Wow.
great case.
All right, Sushil, you're up next.
Excellent. So I'm gonna try and go quick because I want to get to Steve's case. I'll go through here's my disclosures. A relatively quick history. About an 85-year-old woman who had an MBR in 2016, AFib, has CLL but stable, and a history of temporal arteritis, who basically presented with progressive dyspnea, ventricular orthopnea, and NYHA class 3 symptoms. Actually, a retired nurse. She had an exam. She's sort of a thin, tall woman, 59 kilos, 163 centimeters. Her labs you see there, creatinine's 1.1. BNP was very elevated, almost 8,000. EKG was AFib with ventricular pacing. Here's her echo. She has significant aortic regurgitation. You know, you have a peak velocity of 3 across the valve. Valve area is fine, but there's a severe AR with the central coaptation gap. This is a native aortic valve. The etiology of it's not unclear, and I'm going to raise one issue in just a second. Her surgical mitral valve has mild to moderate MS and mild MR, and her tricuspid has mild TR. LV functions normal. Here's her coronaries. You see here, she's got a pacer already in place. You see a mitral valve. She's got some diffuse disease, but nothing clear. The one thing I will say in terms of the etiology, she has this history of vasculitis, temporal arteritis. And when we got the CTA for her aortic, they noted that she had diffuse vasculitis of her aorta. So whether that's playing a role in the etiology of her AR is one question, because we don't have a clear reason. There's no endocarditis, no other etiology.
I was just gonna say, Sushil, her coronaries look a little odd.
Yeah, there's something
beady.
Yeah, so we had her see room actually. I didn't go into all that, but we had her see room. They got a PET scan, all sorts of evaluation, and didn't come up with a clear explanation. And they decided that there was nothing that they wanted to start immunosuppression or any other therapies for at this point, because she's 85 and otherwise really no other complications from it. So this is her CT, and what you see here, here's her mitral prosthesis and some ingrowth of tissue. This is the annulus. It's sort of hard to measure the annulus, but the perimeter 68, area is 331. Her sinuses are pretty big, 27 in the smallest, but go as high as 32. And this is sort of our 3-Mencio analysis. And what you see here again, you measure up, you get as high as 70, measure a little lower, you get 67. The angle of the aorta looks pretty good. But what you see here is the mitral valve prosthesis. The strut is into the LVOT. Usually the surgeons sort of align it so the strut's not sitting in the LVOT, but here it is. And on the CT as well, you can see the central coaptation gap. When we're looking at it, this is the double oblique view, and you see again the mitral prosthesis and the strut sitting directly in the LVOT. And so that comes into play here in terms of the decision making. This is a little video, and I just sort of do this just to see, the vessels are just all thick and abnormal. And that's what the radiologist really commented on, especially when you go down to the common iliac and distal abdominal aorta, really thickened. I guess I'm scrolling a little quick here. Sorry. so maybe I should stop here. 85, severe AR, symptomatic. Her STS is only 4.6, but she was felt to be very high risk for surgery and frail. So
Boy, this is a tough one. I didn't see any aortic calcification.
no, the calcium score was 0, actually.
So
It also looked like her sinuses were kind of effaced. I know you said they were adequate size, but they look a little shy.
Yeah, they're like 28, 27, 28, yeah. The aorta STJ is 32. Sort of, you see gets bigger there. And just if the slides are bad, this is today's case. At the last minute, this is the case from today. So I just made the slides today.
Well. Did you anticipate, so what I was going to ask you, Sheila, is since you have no calcification in the aortic valve, did you anticipate that mitral valve prosthesis will help you or hurt you in implantation of whatever valve?
Yeah, so it's interesting. So initially we screened her for Yena-valve. We're in the Yena-valve trial. They didn't like the fact that the mitral prosthesis, there was basically 2 or 3 millimeters to the aortic annulus. And so she was excluded from the Yena-valve study. So, we, in the mitral prosthesis and the strut and the LVOT, I think helps us. So we had done one other case before, an acute post-surgery that had an MVR, and I think a stitch went into the aortic cusp and created severe central AR. We had done one with Vinny when he was here, and where it acutely basically put a core valve, and the idea is that it would basically come down to that strut, and that strut sitting there will actually keep it from going too low, and you'll sort of sit right on that mitral sewing ring, and the strut will also help support you with a core valve. You can't do a balloon expandable here. I mean, people have done balloon expandable for AI. In general, with AI, we've done core valves with the Sapien inside. But you can't do a balloon expandable here because that strut is just going to embolize everything aortic. Mm-hmm. So outside of Yena, which we thought would work, but because from a trial inclusion criteria she was excluded, the thought was to do a 26 core valve because we got a perimeter of like 68, 69.
I'm interested to know if there is.
Sorry, go ahead, Joel.
I'm sorry. No, so how long ago was the mitral valve surgery done?
2016.
I wonder if there is something anatomically wrong, that might have pulled some of the aortic cusp because the jet is so eccentric. We have another slide that the leaflet might be restricted, and really frozen. And AI can be tolerated for quite some time, as a valve disease that the ventricle is already dilated there. Can be tolerated for quite a long period of time. We know about that.
No, good point. Yeah,
especially. Well, I think what happened was most likely they oversewed and pulled on the intervalvular fibrosa, and that intervalvular fibrosa is connected to right where their picture is, and that's likely causing the AR.
Yeah.
I have to tell you that you'd like to oversize the core valve on this case, but I don't think your sinuses are going to let you get away with this.
So I think we had a debate about that. Our concern with oversizing is it's going to hit here, and that would be too much force and actually pop it up, make it go higher. That was my concern.
Yeah.
Okay.
Well, one important thing, of course, because of the protrusion of the mitral valve, but also because you don't have calcium, right? You want to make sure. I'm gonna go back to the shallow implant, that you do a shallow implantation to maximize the oversizing that you do here. Otherwise, if you go deep, assuming you don't have the mitral valve there in place, right? Like any other case that are treating pure AI, just have to be careful with the fact that you need to go shallow to maximize the oversizing and prevent the valve from moving ventricular.
Okay, so then a quick question for the panel. So if you didn't have that valve strut, how would you size an evolute for AR? We already heard Sushil's going to do true sizing essentially to keep it from 5. Would you oversize it if there wasn't a strut there to push you out of the way?
I'd oversize it as long as my sinuses were okay. I don't think these sinuses are quite large enough to go the next size up.
Yeah. And Steve, what is your ideal oversizing percentage for AR with evolute?
Well, I'd like to go between 15 and 25% rather than anywhere from 6 to 15%.
Yeah, I think a 15% is sort of a magic number that I use. But 68, if you implant shallow, I think you're going to be fine.
Okay, so this is our aortogram, and so, you know, in terms of the views, I was really trying to, from the CT, get a view, because I'm just trying to land it on the mitral prosthesis. That's sort of my goal, and because it's going to settle down to where it wants to settle down to, right? Wherever, as long as I'm, you know, in the annulus, it's just going to settle down to that mitral prosthesis. So, you know, I wanted there on what I don't have is the echo at the time, but in this implant there was still a leak here, and we thought we could get closer to the mitral prosthesis because I wanted it to really settle and be comfortable on that mitral prosthesis. So I left it there. I didn't leave it there. I mean, I recaptured, and here's the recapture on the back, and I did it during rapid pacing at like 120, 140. We went in a little bit here. The frame is a little deformed. We're caught on some of that mitral sewing ring. And so I went lower and just basically let it expand onto the ring, a little bit lower here. But because there's no calcium, the idea was I'm on the outer curve here. And so then as I just basically, I pulled up and this part came down because there's no calcium.
Can I ask a question? Sorry to interrupt you. Could you go back to your prior slide?
This one?
Yeah, could you play that?
Sure.
I actually love that deployment. So my question is,
I knew you were going to say that. I knew you were going to say that.
My question is, why did you react to that picture? My question is, the reaction that you had to recapture this valve was because you felt it was too shallow, or did you react to the leak, right? Because I mean, we know the valve is not fully expanded, therefore you may have leak, which is gonna go away. So I think this is an important topic of discussion because, I mean, the reaction, why did you react to that and recapture the valve?
I think if this was a AS case, this position would be okay. I would have been comfortable with it. I had a plan before based on the CT that I wanted the valve to settle to the sewing ring and the strut, and that's where I felt it was going to be there. And I wanted to pull up here and sort of get coaxial and have this side drop and really sort of stay, because based on CT, I felt that if I could be it would be 2 millimeters below all around would be the perfect position. So the idea was I wanted this side a little bit lower, and if I released here, you're right, it probably would have dropped because there's not calcium. It might have just dropped on its own to that position. But I thought, I would try to get it to that position.
I like your strategy, Sushil. You already have a pacemaker in place. You have nothing to lose. You're trying to prevent PVL. You're going to get a great gradient no matter where you are here. I was also intrigued that, really, we've talked about deploying in an LEO view, cusp overlap in the REO. You're deploying off of a mitral annular ring.
Right, that's what I wanted to say.
The first.
That's a case report. Your pigtail's like somewhere in the aorta.
Yeah.
You use it for the deployment. It's really an interesting technique. I like it.
A quick question for Guy. So your high implant approach, you do that regardless of the aortic valve calcification?
Yes, I would have been happy probably with this initial. I think the initial position that Sushil got was very good there.
And Guy, what if you had then that you deploy, now you have PVL and you got important PVL then? What would you have done then? Because you're already high.
Well, João, the question is, if you're high, you're maximizing oversizing, right? I mean, if you have PVL, right, after you fully deploy because I mean, when you take this picture, you don't care about the PVL because the valve is not fully expanded, right? So after the valve is completely deployed, right? If I have PVL, if I am too high, if I miss, well, then you have to fix the problem. If I missed, right? If there is an aortic embolization, then I have to fix the problem, right?
Yeah.
I mean, I think, again, in that position, maximizing oversizing, I think I would doubt that he would have a aortic embolization. But again, I think it's a great insight. I think
sort of more risk benefit, as to Steve said. My thought was, listen, I just want to get my fiddle there. And so if you look at this position and then the next before deployment, you see how it pulled and this side dropped and this side came up.
Yep. And when you do this, you're rapid pacing on deployment, right, Sushil? I mean, I think that's really helpful for AI, is to pace to stop the heart.
Sushil, can I make one comment here? Yeah. Could you? So one thing, I have two questions. Number one question is, I see that you have a TE probe there. My question is, how much is that TE helping you in the decision-making process in this deployment? The question number two is, I see that the deployment that you're doing here is a very fast deployment, right? So you're releasing the energy of the valve very quickly. This is one of the things that when I implant high, I never deploy the valve like that in a very quick way, because when you release the energy of the capsule there, of the delivery system very quickly, that's a risk of having aortic embolization. So this is one of the things that I pay very careful attention. And it takes me to release the valve like a minute, really, to very slowly deploy the valve and let the valve expand and adapt to the annulus and hold in place.
So I agree. In general, we're slower. In AS, we're definitely slower. You know, we'd been, the bottom part of the valve had been in for a while. You know, for the most part, I thought, you know, had been in well. The TE here helped quite a bit for me. One, we were resizing. You know, we could really see the position landing down on the annulus. And, you know, could you have done this awake? Yes, but it's one of those things, you know, it's for pure AR, no calcium, you know, putting the patient to sleep, getting the images and understanding what you're dealing with. You know, theoretically, you could injure the mitral prosthesis depending on where it is related to that strut. And, you know, and I think there's sometimes the, the desire to avoid general anesthesia is important, but I don't think it's necessary in every scenario. And then obviously the nose cone thing is was the big concern, but we made sure that the wire stayed central and then everything stayed central.
I think it's just an amazing case.
Great.
Wow, look at that. AR is really well addressed. Wow.
Beautiful result.
Yeah, very good indeed.
And there's the T. And also it gives us nice pictures.
Yep.
And it's actually interesting here. You see the mitral prosthesis. The leaflet is not hitting it. You see or it comes close to it. This is the edge of the core valve frame. This is in the LVOT. This is that strut right in the middle of the LVOT, the 3D. And you see this leaflet comes right to here.
Beautiful.
This is Becky's images, huh?
Well,
Omar. This is Omar. Today.
Omar,
yeah. Oh, you have Becky or Omar there. How can
you got two of the best.
You gotta let them take the pictures.
So, but I had to grab slides quickly. So this was from today. She got extubated, did well. So it was a interesting
Great
case.
job.
That's fantastic. So one last question. I mean, what's everybody's comfort level with doing Evolute for AR cases?
High.
Start with the
Hi.
high.
Yeah, we use it for AR if we need to. We don't have JenaValve yet. I think when we have JenaValve, we'll be happy to be part of that trial. But we've used CoreValve in a number of AI cases.
So can I just ask? So when you guys say high, do you even consider the aortic valve calcification or anything like that, or do you just treat it just like a native AS case?
We definitely consider the aortic valve calcification, whether they have any surgical eligibility. If you have zero calcium, you have potential trouble on your hands.
Yeah, I think, of course, doing a pure AI case is just for really non-operable patients, even for obvious reasons, right? So, but yes, when this is the case, basically one thing that I consider significant is the amount of oversizing, the conversation we were having before. If we can do at least like 15% oversizing, then I would do the case very similarly to how I do aortic stenosis cases. I would pace the patient in a higher rate and always keep a forward tension in the wire, because the valves, they tend to dive down and not up. And I try to keep the shallow implant just like I do for my aortic stenosis case to maximize oversizing.
Sushil?
Yeah, I agree the same. I mean, I think there's, as long as you can do oversizing, I think I feel comfortable. But you know, we've had a case where we've had to put sapien inside, right? It dove deep and we had to pull it up, and it would, you know, it's not going to stay, and use that basically as an expensive, you know, stent to hold the sapien.
When you put the sapien aside, you have a snare holding the Evolute while you do it?
Yes. Yeah.
Just asking, on the topic of AI use in Evolut, any experience that you guys have had with LVADs, with AI, post LVADs?
So we actually did a really nice, interesting case, LVAD AI, and there was a lot of room for oversizing. So we did a Lotus in it, and it worked really well because these leaflets had some thrombus on them. There's a lot of contact points, enough oversizing, and it got a nice result with the Lotus in it. But I think Evolut would be fine as well.
Yeah, we're gonna actually do a case a couple of weeks from now. Patient coming from out of state, but we have done cases with LVAD.
With the Lotus key, is that what you're asking?
No, with Evolut, not with Lotus. Sorry, with Evolut.
With an LVAD.
Yes.
Yeah.
We've looked at them. We haven't done them yet. I would love to do them. I do get worried that the LVAD could suck it into the LV, which would be absolutely disastrous. But I would love to do it. But we'll move on here. We've got to move on to the last case here. Last but not least, Steve.
Let's see. Yeah, I'm going to talk today. I'll be brief here. This is a 74-year-old man with prior bypass and an Epic BioCore valve in 2014, surgical valve, shortness of breath for 2 months and a STS score of 5. He was being worked up for TAVR. He hadn't quite come down for his CT scan. While he was awaiting his evaluation, he developed severe sudden shortness of breath and heart failure requiring hospitalization. So I don't know if I have control of my slides. There we go. And so despite IV diuresis at an outside institution, his shortness of breath worsened and he needed to be transferred emergently for heart failure management / whatever on a Saturday. It always happens. So fortunately then, his blood pressure is 100/36. He's really in cardiogenic shock to some extent. BNP's off to the races, and his creatinine had climbed from 2 to 2.8 in the past day. So you can see his echo on the left. He has severe aortic insufficiency. The echo in the middle, you could see it's a torn leaflet off of the surgical valve, and then on the right you can see how much torrential aortic insufficiency there is. So the question is how do you plan his access? You don't know what his legs look like. You don't know how to do the case, what valve to use, embolic protection. What do you do here? Who would use embolic protection on valve and valve? I don't think we touched on that.
I would. Sorry.
No, go ahead, Sushil.
Go ahead, Sushil.
No, I would. I mean, I think these leaflets are so degenerated, so abnormal, and I think the risks are high. So, but I'm a big believer. I use it fairly routinely in all of my cases, so I have a low threshold.
I have a question about the access, Steve. You cannot put this patient through a CT scan?
No.
No way.
I don't think so. The creatinine's going up really. Actually, he was transferred down in kind of shock. I felt like he had to go to the lab right away.
Yeah. So we did a similar case like this. We just did peripheral IVUS.
Yeah.
Peripheral IVUS works really well, and then sizing we did TE, 3D TE for the preliminary, and it worked quite well too.
And when you're going to do a valve and valve, you probably don't have to use any dye. So one of the things you can just do is do one shot of the leg that you cannulated and go.
I think the one thing I would say, Steve, is like what you did, and these patients, it's amazing how quickly they fall apart, these bioprosthetic valve once they get AI. But it's also just as amazing how quickly, if you treat them that day or the next day, how quickly they turn around as well. In renal failure and shock, and then the next day they're turned around.
Totally agree. So
not delay,
yeah. So here's the valve procedure. This was implanted in our usual technique. It's a little deep. Guy's probably having spasms over there. It is a valve and valve. I usually go a couple of millimeters below the surgical valve. It's hard to see these biocores, and the pigtail's never really down at the bottom of the annulus, but I do keep it a couple of millimeters below just because I like to post-dilate afterwards, which is what happened here, just so that I made sure that the valve is fully expanded to the surgical valve. And of course, he had a beautiful result. So the real point I want to make here is there's another case of a of a patient who went to surgery, who had severe aortic stenosis that nobody knew about. Nobody listened to the patient before they went for their emergency procedure, had severe aortic stenosis. We implanted a valve immediately post-op because the patient was hypoxic and heart failure. So what I really wanted to point out is we have TAVR going on in lots and lots of places across the country. Who's ready to do this as an emergency procedure like we do PCI?
So I have I think the situation that you showed, Steve, beautifully showed, and Sushil made a very important comment there, that these patients, they turn around very quickly, right? I think the only situation that I think emergent TAVR is reasonable is the situation that you just described, the patient that has a bioprosthesis, that has acute AI or subacute AI because of a torn leaflet. And indeed, these patients decompensate very quickly. We've had some cases here. Actually, there was a case that I presented on CVI a couple of years ago of a patient that we did a valve-in-valve in a freestyle. That it's really impressive how they recover. I do not think there's the paper that just came out on jack intervention recently from the TVT registry, and we published our internal data of 700 patients back then, years ago, of the urgent/emergent TAVR. And these patients for emergent, they just don't do well, right? So my view of this is, if there is a patient with hemodynamic compromise or any other issues with severe aortic stenosis, there's no emergent TAVR. Emergency is a BAV as a bridge. The only exception would be acute or subacute AI in a patient like the one you just described. I don't know what the opinion of the others are.
What about the patient with cardiogenic shock, severe LV dysfunction, and severe tight AS as well that presents way too late?
BAV. No emergent TAVR.
Decision?
No emergent TAVR, João. A patient in cardiogenic shock, severe AS, emergent TAVR is a big no-go.
So the challenge here is this. So I think to Joao's point, though, I think it's important. I mean, EF of 20%, when you do a BAV, they're not going to turn around. So the question is, your best chance of turning around is to replace the valve. But now we all of us do high enough volumes, we can take a hit with the TVT registry and looking at our outcomes. A site that does 20 cases a year is not going to be able to do that. And I think that's the reality. But I think we would all agree that the best chance of that patient recovering, especially with severe LV dysfunction, when TAVR was a 24 French sheath and BAV was a 12 French sheath, it was an argument, right? Now you're 14 French, and in the argument, yes, the infection risk. So if someone's infected, that's a different scenario because you risk infecting the valve. But it's a challenging thing, and we go through it. We've done 2 in the last year where we did BAVs because someone was going to surgery or something, and we said we'll do a BAV, and then they had severe AI, and you end up doing a TAVR acutely in that same setting because they were in shock with the AI from the BAV. But they're challenging. This is a challenging question.
We've had several emergent cases, and I've gotten calls in the middle of the night or the weekends to do them. And in one case in particular, we did no contrast whatsoever because the creatinine was very high. And I actually did 2 pigtails, one in the non and one in the left, and peripheral IVUS. And then we did a T just to make sure, and it went beautiful. And so I do think it is possible. To the point about the BAV, I worry about some of the incomplete relief of the AS and how that may affect how quickly a patient recovers. I think you have a point. I mean, if you get a fantastic BAV result, then awesome. But I think unfortunately, and at least in some of my experiences, the gradient really gets the valve over 1.
Yeah, no, I think again, it's feasible. We've had many cases in the past, some of them very successful. I mean, the procedure, as we know, the procedure is successful. What comes after the procedure is the issue, right? As Sushil pointed out, with reduction in catheter sizes and everything, the rates of complications are low. What happens in the aftermath is the big problem, right? We've had great cases, and actually in our paper showed that it's feasible. The procedure is feasible. However, of course, all of these patients, they have all increased complications down the road, right? I'm skeptical of doing urgent in patients with cardiogenic shock. I think still my to-go procedure is BAV. I really am very careful on selecting an emergent TAVR procedure. We've done a lot. I think today I'm very careful on picking these patients. I actually saw a patient today. She has a gradient of 100, mean gradient of 101.
Oh my gosh.
I don't know how this is even possible, but yeah. Thankfully, she's actually trained in a good direction with medical management, and she's gonna be an inpatient TAVR, but not an emergent TAVR. If I had to do something emergent for this patient, I would do a BAV.
Yeah, but even with a BAV, a gradient of 100, you can only get it down to maybe 50, don't you think? I mean, but maybe 40. It's still severe, right?
Yeah, but it might be enough to turn her around. That's my point, Paul. Because I mean, if you have a patient with in like kidney failure, you know, and you know, liver failure, this is not gonna do well. I mean, we've had many cases, and again, great results, technically speaking, great results, but the result down the road is not so consistent. So I'm a little skeptical of doing emergent TAVR. I think it's a very controversial topic. Anyway, that's my.
Oh, here, well, one quick question at the end here, because there's a question about BAV and then Impella. Would you rather do that?
I've done that actually. Oh yeah, I've done that definitely. I did a case 3 or 4 weeks ago in a 93-year-old patient, but very good looking 93-year-old patient. Cardiogenic shock, severe aortic stenosis, BAV, Impella. He did well actually, you know, initially, but then other problems happened. But he did well from the procedural standpoint and from the hemodynamic support, and then other issues happened along the way, not related to the intervention. But yes, we've done that before.
Oh, well, this is fantastic, guys. And I just want to thank you all for wonderful symposium. I think this is just, I mean, always learning a lot from all of you. And Guy, you're my role model for high implants, as always. So for those of you who are interested in claiming CME credit, you can go to this website and claim and do an evaluation and get the credit. And it's good for a year. And then our next webinar will be this complication management course, a session on October 1st. So thanks again to all the speakers. Fantastic discussion. I miss seeing you guys, really missing you. And I hope we get to see each other in person very, very soon. Okay.
Yeah. Thanks for having us.
Thanks so much.
Yeah, everyone.
Thank you.
Nice seeing everyone.
Guys, thank you.
Thank you.
Bye.
Bye.